mentioned that we do want at this meeting to check that you're happy about the way your initiatives are mentioned in the draft letter to Wes Streeting. And we particularly today want to say something about how the social services could link or be involved in each of those initiatives, because it's we have neglected that area.
Okay, thanks, Paul. Yes, good evening, everybody. Just on the question of social care participation in this, and to reiterate, Paul, what you and I said in our conversation, I think that it would be helpful to see whether we can garner support from BASWA, the British Association of Social Workers, with whom I, as one or two people on this call will know, made a film about the life of my late wife, who was a social worker, and which is being disseminated in various higher education places and being used to support learning around social work and almost reimagining social work for something it has long since, rather unfortunately, ceased to be, which is part of the system which can both do work that is necessary on safeguarding and risk management, but is also very much tied in with community development and community building as once it was. So I think that the sense and spirit of the film has some congruence with what we're discussing now.
Whether we should make more reference to links. I mean, what about referencing the film to Daphne, about Daphne, as part of what we mean by this is, and then pointing in that direction with understanding the social care crisis?
I think it's best sold as a key dimension in integration, as understood by health colleagues and health policymakers, is very much broader and more imaginative than organisational integration between parts of the system. And in that sense, social work ought to be quite key, but it does mean revisiting some of the places that social work came from, some of the history of social work, at least as much as where social work is now, which is in a very limited place, it seems to me.
Yes.
Sending it to those people across London, for starters, and also the comment that's just been made about integrating social care into what you're doing is totally, I would have thought, the right way to go.
The palliative care may know more about how to manage these things than other people, but they can't do it all. It's too late to get into thinking about integration when somebody's about to die. You need to have thought of it way upstream.
That there is about to be quite a substantial piece of work undertaken by the Department of Health and Social Care in the UK, looking at developing a social work policy. And we know some of the bare bones of that. But there is going to be much greater sort of flesh on that detail within the first quarter of 2025, separate parallel worlds. So true integration is, I think, always going to be slightly elusive until we get a much stronger narrative coming together around health and care.
If we've got a solution in certain areas, and I say that shift to community-based services, then people of influence may be heavily targeted.
There's a fair chance that we'll have separate policies. Most people who've done innovation do it despite the bloody rules and the structures and everything else. And that's the sort of people we might want to hit in our round-robin letter that goes to people who might want to do something. And it may be that it's an ICB that picks this up, and from that bottom up or middle up, we can build a prop. So that's why I want a more scattergun approach, but a focused scattergun. Because often it's got to be maybe more bottom up or middle up that might actually do the
About March time this year, Penny Dash and Paul Corrigan put together a report. The thrust of that was the use of market tools to support integrated care at kind of level of place.
Of course, the main message we've got I think, is that the idea of localism and collaboration for health and care is that the government seems to be talking about is fantastic idea. The danger is it's going to go off the edge of a cliff by protocolizing it, making everything you must do this, you must collaborate, and you must love everyone, rather than knowing how you help people to collaborate and love everyone.
But an innovative concept, which we're trying to communicate to numerous sectors, needs to stand out, not too wacky, and it must speak in different languages to the different sectors. So if it were looking completely from outside of this thing, I would be trying to engage a graphic designer.
And how the young people do things is social media, thinking about other ways of being influential, which isn't the first task. But I agree with Greg that the next task in dissemination is to think broadly in how the message is delivered, as well as the points in a well-written letter.
I think it's about us starting with the fact that there are communities. They're there in different shapes and sizes and formats, and that really is our starting point. This is the resource that we are wanting to engage professional staff with.
We're also talking about how you purposefully develop communities, not simply work with ones that are already established and known to be there, but how you develop a sense of we rather than I.
So that I think rather than people perhaps changing the content of the paper, it's the email that would need to be modified according to who it's being sent to.
Collaboration is, of course, important and old hat in one sense. I think the thing why I've been excited about the COIN work, is because this includes the citizen as well as the lay people as well as the professionals. That's the bit that I think is most exciting. And that's the bit, if we're going to reform our health and care system, is where we have to go rather than other structural change, which I suspect we'll get. It's how can we get participation from lay people as well? So that's a new way. So my view is that's the reform that we're after.
No, I'm quite happy with that. I think, yeah, it says exactly what we're going to do, which is to run a session on community-orientated care. I mean, general practices now do have more links with social services in the form of things like care coordinators and that are linked with PCNs. You ought to have per 1,000 registered patients, X percentage of a social prescriber. If you wanted to formalize it and make it more equitable, something like that.
There have been suggestions, for example, of having one nurse in every school for school-based nursing, which is often very hard to meet. But we're in the process now in states like Michigan and California where there are calls for policy to require hospitals to have so many nurses per so many patients, and it's starting to create a bit of a policy nightmare for unions and movement towards requirements and lawsuits. It's a very American problem, perhaps, but sometimes having a rigid ratio of providers per patients sets up a lot of unintended consequences in my experience.
Well, as you know, we've got quite a lot of national evaluation on the 65 demonstrator sites. It covers 3 million population, so we've got quite a spread of work that is answering two questions. One is why do we continually fail at reducing health inequalities in terms of outcomes for marginalised vulnerable groups? And the second, how much the NHS can do about it. Registration with the NHS does not work for them. So the idea of registering with your GP to get healthcare in vulnerable marginalised groups doesn't work. Place of care doesn't work. There's a whole issue around NHS estates. So, for example, people who don't live with any shelter, then the most successful approaches in 3 of our sites have been to have mobile estate. And many groups who are their health outcomes are trying to be improved, whether it be children in areas of high poverty with obesity. They do not want to go to their GP. They do not want the service in school. They do not want it in the community centre. So finding the right place of care, which has been really innovative in some of these sites, health literacy, to improve people's health, we still send them texts and letters to people who have sold their phones to pay the fuel bill or don't have a letterbox. But if we don't do it, you got 3 strikes and you're out with the NHS. There's a whole range of things, language empathy, interpretation services in the NHS do not work for people who are living in high areas of poverty with English as not their first language. But we found a way of translating, rather than the language concordance of just changing the words, into changing the feelings of an individual interacting with their healer. And it's really eye-opening. The NHS website will have all sorts of interpreters. They don't work. Biggest issue is for our health and care system is allocative value. And I've spoken about this exhaustively. So, when we're talking about social services and social interaction, we're not interested in funding it. We're only interested in reducing waiting lists in hospitals. So if you've got a non-recurring sum of money, you can only spend it once. I've said this a bit emotively, but it's true now. If you've got £15,000 and you can spend it on a white middle-aged man who needs to get back on the golf course by having a hip replacement and votes, or you can spend the same amount of money on 6 families with complex care needs, with children with mental health problems who go to bed at night with their bellies empty, and you can look after them for 6 months. Where are you going to spend your money? Every time on the hip replacement. A whole range of things that link into social determinants back to social care, but unfortunately social services can't deal with any of it.
Sanjeev.
Thanks. As I was hearing James talk, Paul, I did wonder about whether there are any lessons to learn from integration prior to 1972, before health and social care were separated. If you go to Germany, for example, where a lot of the purchase of services is very local and depends upon population need and driven by democratic, local democratic processes, one tends to see sort of that allocative efficiency that James was referring to, perhaps, which is that actually not only is there a value in local delivery, which is integrated, but actually local purchasing, which is also integrated, so that actually we connect the purchasing of health and care services back together with democratic processes, particularly.
What James is saying is, of course, true, but the health service is probably the wrong place to start. I mean, this is why the discussion on social care isn't only about social care, it's about local authorities. A short time during the Blair government, when actually health inequalities did fall for a short time, and one of the things, and it's hard to say whether this is cause and effect, is Blair was very good at connecting at a national level different strands, health service, work and everything. And it strikes me that the main role the health service can have locally, if you want to mimic pulling together a lot of people who can do good work at a very local level and it writ large, is because of our profile, we might want to be the instigator of getting a group together. But I think to leave the health service to think that it will be leading on health inequalities, it has a job to do about health inequalities in access to services and in outcomes, of course. But on the deeper issue that James is raising, I remember Alona Kickbush from Yale used to talk about, that to be healthy in a general sense, it helps to be rich and famous. And what she meant in that facetious way she was talking about is that you need to not have poverty, and you need to have some locus of control in your life, both of which are lacking in people who are underprivileged. And if you were going to tackle some of these issues, which Cohen's thinking might want to go that way, is how do we look beyond healthcare or even social services? To me, social services is almost like the biomedical arm of local authority. that we need to look at a much broader concept of who's going to focus, and it's got to be at a very local level and from bottom up, because it's so complex that trying to do that nationally is almost impossible.
Absolutely want to agree with David about that. I mean, I led the implementation of the National Programme for Social Inclusion and Mental Health, which came out of the second Blair administration. And I was accountable, and the team that I ran was accountable to a cross-government network of high-ranking civil servants, right the way from housing and health through to agriculture, because it was seen as multidimensional. This question of how you challenge exclusion, and there was something about having that cross-government accountability, which has never been really replicated since, and how it fits with local initiatives, and getting that connectivity is fundamentally important. I definitely don't think that we've seen a great deal of evidence in recent years of that being a key way of looking at policy implementation. Well, I mean, I don't think we should be chary about reminding new Labour of that particular episode in its history, where there was an invention of a cross-government approach to these things, a recognition, as with Sure Start, that you needed to think very, very laterally. We've got plenty of evidence of what we did then, and I think we should perhaps just give people a nudge to remember it.
Yeah, just to agree with DCT and Sanjeev about both the reconnection between health and social care in a much more practical way, and some of the things I'm talking about are not going to be solved by the NHS. My point is that if we raise £22 billion to invest in better health outcomes, investing it in building new hospitals or reducing hospital waiting lists will not produce those outcomes, but that's where we're going to invest it. Well, there's good evidence that the NHS is causing some of the problems in itself in social care. It's probably causing some of the problems in education, and why we haven't got enough policemen, how we allocate the public purse. And there's a debate that needs to start around improving social care, addressing the social determinants, the wider determinants, which needs investment, but can't be as well as, because none of us want to pay more tax. We're not very efficient in how we utilise. We can't borrow any more money, and we don't grow money trees. So we've got to reallocate.
You've got to do both, but it could be at a slower pace than you might be wanting. Because if you piss off the public by the immediate service industries, you're not going to win votes. Leadership issue, which I'm not certain if this Labour government has got the Blair imagination, I'm afraid. Well, even the Brown one didn't.
No. And maybe that's where our little network might come in, is helping the narrative.
In the chat, Sanjay Gupta has made the point, one I agree with, that this is really public health we're talking about. This is Marmot's work and the kind of importance of getting people healthy from the grassroots up, basically. That has been said by this government, that they want to improve public health, do they not? That's what they're saying. So can we kind of reinforce the importance of that in our communication with them?
That's a big suggestion, Linda, and an awkward one in a way, because because even the most advanced people in public health are stuck inside a way of thinking that is not necessarily, which just administers community development rather than knows how to make it happen.
I just wanted to agree with what Linda's just said, and just add that it's exemplified by Wes Streeting, in my view, extremely naive belief that he's going to solve the problem of people underemployment and people with mental health problems not going to work with an obesity injection. I mean, it seems to me just completely very upsetting and bizarre that he's obviously been taken along by pharma to sort of think that this is a simple solution to an extremely complex problem.
One of the areas that we haven't touched upon it's been alluded to, is the issue around devolution, Paul, and that actually the devolution of health has, I think, very largely been resisted by the centre. And the consequence of that is that actually the integration of health with local services that go beyond health, whether it's care or education or housing, therefore remains kind of sort of stuck between very local and very national. The consequence of which is there are some unhelpful and inherent barriers to collaborative work that could emerge from a much more localized engagement across those elements, and that sort of disjunct in policy and strategy means that actually we're also circling yet another drain pipe that we can never quite plug. So we end up spending more and more money in health as a solution to the challenges associated with housing and education and social care.
So that would be another argument for
Localization.
finding case studies that we can work with, and I'm particularly thinking of Liverpool and Manchester.
Yeah, absolutely. Yeah, I think so. But again, I think that what we've got to be able to do is to frame it in the context of established policy, so that actually the language of the politicians can understand what it is that we're trying to say here. And that, I think, will make for an interesting and much more attractive sort of conversation, if nothing else. But if we don't actually start to make the arguments around this in that way, I fear that people will read what we're trying to say and it'll just bounce off them.
Yeah.
Good.
That maybe the topic we carry from January forward is a carry-on of the conversation today in this local, national tension, both policy and scaling up from local examples, learning lessons from the models of what occurs locally. So it's not just an anecdote, it's actually something that could be replicated.
Comments that actually, I think the next meeting we should talk a little bit about that sort of local national tension, but also that the problems of general practice are not going to be solved by reforming general practice. It's a waste of money, spending money on general practice. We need to spend the money elsewhere, and general practice will then sort itself out. Popular or unpopular to say, but probably true.
Could everyone think about that and how, because everyone's nodding, but
I haven't read her book, but I watched quite a long speech of hers from a woman called Hilary Cottam. Worth looking it up. And she's saying is that social services are going down the same path of the health service, of having a bureaucracy and targets and cramming people into care and getting them through the system, rather than focusing on the relational side of it. And that echoes a lot of what has happened in general practice, that we're getting into like a glorified outpatient care rather than actually what general practice could add. And not just by GPs, I mean the practice.